all irregular. They're all very densely packed together. They have signs of cell immaturity, which include high NC ratios. They're a bit disorganized. That's normal for the parabasal cell layer. But again, remember, as the cells migrate up the epithelium, their cytomorphology will change. They start maturing. The nucleus starts getting small, cytoplasm starts getting big, the NC ratio begins to decline. That's a sign of maturation. You'll also notice there's some organization in the way the cells have aligned themselves. That's all signs of maturation. By the time they get up to the superficial layer, they have very small nuclei, big cytoplasms, and again, the NC ratio is much smaller. All of that is good indication that this epithelium is maturing properly. We say the epithelium matures properly because the cells within the epithelium are maturing properly. Over to the right here, we have an example of a severe form of cervical dysplasia. Again, most of the time this is caused by an HPV infection. Let's see, again, there's the epithelium, basement membrane, and the subepithelial tissues. We look at the parabasal cell layer. Naturally, all the cells are crowded together. They have high NC ratio. That in and of itself, not a problem. But as the cells migrate upward, you'll notice they don't change their cytomorphology. Nucleus is still big in proportion to the cytoplasm. NC ratios are still very high. There's no sign of organization here. That persists all the way up to the superficial layer where you got these big nuclei and very small cytoplasms. NC ratios are still very high. And throughout the entire thickness of the epithelium, you see no evidence of maturation whatsoever. There's no change in NC ratio. There's no change really the way the cells are organizing. This is an immature epithelium throughout its entire thickness. We call that cervical dysplasia, the dysplastic epithelium. Now, this happens to be a very severe form of epithelium, and we can describe this in a number of different ways. We use a three-tier system to describe the degree of dysplasia. It's called the CIN system. Remember, CIN stands for cervical intraepithelial neoplasm. You look at this epithelium, it consists of cells that are crowding each other, they're over-proliferating, they're not maturing properly. That's what we call a neoplasm. The neoplasm is confined to the epithelium by a basement membrane running over here, so it's a cervical intraepithelial neoplasm. Well, this is a severe form of dysplasia. It's the most severe form. We have a three-tier system describing dysplasia. The system runs from CIN1 to CIN3. This is clearly CIN3. It's a very severe form of dysplasia. Specifically, this severe form of dysplasia is full thickness dysplasia. So we can go one more and describe this as carcinoma in situ, CIS, carcinoma in situ. This is the worst form of dysplasia possible. This is basically cancer just before it becomes cancer. Now, you'll notice that even though the cells are crowding each other, the cells are clearly immature, they are respecting this basement membrane down here that keeps them confined to the epithelium. And as a result, they're not displaying any local invasiveness, which would be one of the defining features of cancer. So you can't call this cancer. There's no evidence of any kind of behavior that would identify this lesion as a cancer. These cells are all confined to the epithelium by a natural tissue barrier, the basement membrane. As a result, there's no evidence of local invasion, and therefore you cannot call this cancer. You can only call this dysplasia. Dysplasia by definition is a benign lesion. Now, there are a few things that we can do here. Okay? Sometimes the woman's own immune system will recognize this dysplastic epithelium as being bad and being a threat, and will attack the dysplastic cells and destroy them. That's probably the best possible outcome that can occur. This dysplastic epithelium will be destroyed and eventually be replaced with a normal epithelium. And if you look in this section, you can see exactly that's what this woman's immune system is doing. You can see an array of inflammatory cells here. They're recognizing this dysplastic epithelium and they're trying to attack. Best possible outcome, it will be successful in destroying all of these dysplastic cells. The cells are wiped out and replaced with a normal epithelium. Very often, a dysplastic cervical epithelium will spontaneously resolve. And that's because the woman's own immune system is taking care of this. There's another possibility: this dysplasia can persist and never give the woman a problem. Simply continue to be a dysplastic epithelium. But there's also another possibility. Sometimes what will happen is that these cells will break through the basement membrane. They're growing, they're mutating, they turn on some sort of enzyme that allows them to break through the basement membrane, and they start invading into the subepithelial tissues. That's called local invasion. When that happens, this is no longer dysplasia. This is a squamous cell carcinoma of the cervix. Yes.
So is it normally taken care of by the immune system? So if like someone's immune compromised, is that kind of when they would see more of like the local invasion when they can't defend against it? Or
If someone's immunocompromised, they are more susceptible to developing many types of cancers. Some specifically associated with an immunocompromised state, like Kaposi sarcoma. But just in general, when immunosurveillance declines, they do tend to develop cancers. Okay, again, most of these caused by HPV. The peak age at which women develop cervical dysplasia is around 30 years of age. 30 years of age. That's the peak incidence where we see cervical dysplasias. Yes.
what determines the CIS levels and how far it goes?
Yes, so you can have, let's say, dysplasia up to here. I mean, this would be more like CIN1. CIN1, if it goes up to here, maybe CIN2. You know, from up here, possibly up to here, you got CIN3. Also, the cytomorphology of the specific cells will influence what the pathologist assigns a higher grade. There's variability between what pathologists will, how pathologists will grade the dysplasia. Someone will say, oh, this is CIN2. Others will say that same thing is CIN3. There's no very specific quantitative way of defining. But this is generally how. Okay, so the peak incidence for dysplasia again is around age 30. Now, again, this could resolve, it can remain, persist, but it can also develop into a locally invasive squamous cell carcinoma. If it's going to develop into a squamous cell carcinoma, it'll do so about 15 years. In about 15 years. Peak age for the development of squamous cell carcinoma is around age 45. Let's take a look at what a locally invasive squamous cell carcinoma looks like. Here's another section through a cervix. Okay, we have the cervical os is right here. Okay, it's kind of filled in with some keratin. We've got some normal epithelium here. And remember, we've got a basement membrane running right down here. So we look at this normal epithelium. And even at this low power, you can tell that the epithelium is maturing properly. You can tell by the way it's staining. Parabasal cell layers, you notice you got this hyperchromasia. There's some dark staining. That's because all the nuclei are kind of close together, crowded. They're immature. They're replicating. They're supposed to be immature. But you'll notice that as the cells migrate upward, the staining pattern changes. And that's because the cells are spreading out, they're organized, maturing, nucleus is getting smaller, cytoplasm getting bigger. Everything here is normal. You go over to the left over here, and you'll notice there is an area here where you have full thickness hyperchromasia, there's full thickness dark staining. That's because all the cells are crowded in that area. They're overcrowding. Clearly, that's a neoplasm. Okay, all crowded together, they're not maturing properly. Now, if that were the only problem, we'd just call this dysplasia, but that's not the only problem. If you look over here, you can see where some of the cells have broken through the basement membrane, and they're actually forming little colonies of neoplastic cells. Well, this is called local invasion. Local invasion is a defining feature of cancer. This is a squamous cell carcinoma. Okay, just beginning to invade. And peak age for this to develop would be about 15 years after dysplasia. On average, about 45 years of age. Let's take a look at this cancer. Let's take a look at a normal cervix. So we've seen the normal cervix before. This is transverse section through the vaginal canal. You can see the vaginal mucosa down here. This is the vaginal canal. You can see rural folds in the vaginal mucosa. This, of course, is the uterus. You can see the cervix here. And there's the fundus in the background. You can see the cervical os here. This exterior is called the ectocervix. Again, it should be smooth and very reflective. And that indicates really there's no inflammation present. That all looks very normal. Okay, usually the cervical os in a nulliparous woman is round like this. This cervical os seems a little oblong, probably because this woman's multiparous, birth multiple times. Usually the morphology of the cervical os will change. That's the shape of a cervical os in a nulliparous woman who's not given birth. But in a multiparous woman, usually it gets kind of ovoid like that. Okay, so this woman's probably given birth a few times. Everything is normal though. The cervix looks good, and the fundus looks good. There's nothing to see. Okay, this is what squamous cell carcinoma would look like. Okay, we've got the cervix here. This is the ectocervix right here. The cervical os should be right here. Again, you don't see the cervical os because it seems like it is filled with some nodular masses that you see here. Those nodular masses are squamous cell carcinoma. And this is kind of an advanced squamous cell carcinoma. That's what it would look like. Mostly. Okay, let's take a look at the causative agent. This is HPV, and HPV usually is the troublemaker. It accounts for 90% more of the cervical cancers that we develop. And we'll talk about some of the different presenting symptoms of cervical cancer. Okay, usually, not always, but usually, HP is transmitted sexually. It doesn't have to be. Sometimes people will contract an HPV infection from a fomite. Fomite means an inanimate object like toilets, or contaminated clothing, towels, or something like that. So HPV doesn't have to be transmitted sexually, it usually is. Okay? Millions of people exposed to various serotypes of the virus every year. Some of those exposures are to the low-risk serotypes of HPV, things like serotypes 6 and 11. Those are non-oncogenic serotypes. They're sometimes called benign serotypes, non-oncogenic serotypes. Worst thing that can happen to these individuals is that they develop condylomas. Not even everybody develops condylomas. Condylomas, venereal warts. Okay, that's generally what happens with 6 and 11. A person would develop condylomas, and maybe hundreds of thousands of years will be exposed to these benign serotypes and develop these condylomas. Then we got people who are exposed to the higher risk categories. These are the oncogenic serotypes again, 16, 18, 31. There are actually many of them, but those are some of the more common oncogenic serotypes. These are serotypes of HPV that can integrate their DNA into host chromosomal DNA, really disrupt the genome of the cells. As a result of that, a few million people per year will develop some form of cervical intraepithelial neoplasia, CIN. Okay, maybe some mild forms of CIN. A million people a year will develop that. If the infection persists, then it can develop into a higher grade CIN. Maybe a third of them will go on to develop CIN3 or something like that. But some higher grade dysplasia. About 15,000 a year will develop invasive cancer. Okay, that would be locally invasive cancer. And of that, about a third will develop significant metastatic disease. Now, these are the individuals that really get into trouble here. About 5,000 a year. The cancer isn't detected in time. It's not detected so that we can treat it when it's still a localized cancer. If it's a localized cancer, we can perform a total abdominal hysterectomy. Again, if we can resect all of the cancer cells, then we can achieve a cure. Okay, that would happen if we caught it early. But once the cancer metastasizes, a local resection isn't going to cure anything. You have to supplement that with chemotherapy. And chemotherapy doesn't always work completely. And so, depending upon how extensive metastatic disease is when we catch it, a lot of these people will eventually succumb to the effects of the squamous cell carcinoma.
Doing the hysterectomy, even if it has metastasized, still help with like future chemo treatments, just because you're removing at least that bad organ tissue.
Yeah, to that degree, it's more like debulking the cancer. If you debulk the cancer, while you're in there, you're really not going to just kind of resect the visible cancer. You're just going to take out all the organ tissues that are associated with that. In so doing, you are debulking. And of course, it takes a load off of the metabolic load off the patient as well. So you got to follow that up with chemo. Even if a person had a section of tissue that had cancer in it, you couldn't resect all the tissue. You would still go in and debulk the tumor. What happens is if you do that, you debulk the tumor, the remaining tumor cells that you haven't taken out, they tend to enter the mitotic cycle and they start proliferating again. And that's when they're most vulnerable to chemo. So you make them vulnerable to chemo by removing a lot of the competition, competitive tumor cells. It sounds a little perhaps counterintuitive, but if you get the cells to start rapidly replicating again with chemo, that's wonderful. Anything else here? Yes.
So I know there's like 150 strains of HPV or something like that. Do you have multiple strains at the same time?
Yeah, multiple serotypes. Some of the serotypes are more likely to be propagated than others because they're more durable, they last longer in a harsher environment, and so you can get multiple serotypes communicated. 16 and 18 happen to be the more prominent. They tend to be the more easily communicated. They're served better. But you can have 16, 18, 31, and 33 all at the same time. Plus, you can have some of the benign serotypes at the same time. So this could present with dysplasia, condylomas.
I assume the Gardasil vaccine then works for the heavy dose.
If I remember correctly, it's a tetravalent vaccine. It covers 6 and 11 as well as 16 and 18.
I think it's up to 9. That's ours.
Yes, I've heard that, right? There's a new polyvalent version. The original version, I think, was tetravalent. You keep adding serotypes. Try to cover the more prevalent. Anything else? Let's take a look. Again, some of those features. So I mentioned how the dysplasia is graded against the CIN system, three-tier system. Presentation on abstract, you're going to see atypical squames. You will see strange-looking squames. A lot of INC ratios, abnormal morphologies. Depending on how bad it is, will allow the pathologist, the cytologist to determine whether it's a plastic cell or whether that's actually a cancer cell. Ultimately, when I have to do a biopsy, determine the nature of these odd-looking cells, that will give you a much better indication if you're dealing with dysplasia or cancer. The management, assuming it's a dysplastic lesion, you can perform an ablation procedure. All you have to do is destroy the dysplastic epithelium. You don't have to necessarily do a whole hysterectomy. All you have to do is destroy that part of the epithelium which is dysplastic. That can be done with laser, can be done with biosurgery, electrocautery. There are just many different ways. Chemical treatment, there are many different ways. If someone has a very severe dysplastic cervix, there are a number of options that person can have. They can have limited hysterectomy, or they can opt for something called cone biopsy, which is both diagnostic and therapeutic. Cone biopsy is a procedure where we cut out that part of the cervix which is most likely to give rise to a cancer. We're cutting out the interior right at the transition zone where the squamous epithelium becomes the mucous-secreting columnar epithelium of the endocervical canal. You go in, if you cut that part out, which is the interior of the cervix, you resect the transition zone, you dramatically reduce the possibility of a dysplasia developing into cancer. Now, when you do this, you cut out the cervix, you leave the cervix incompetent, meaning it can't retain a gestation early on. So if a woman is going to have a cone procedure and she's going to subsequently get pregnant, she's going to have help retaining the fetus. Otherwise, the cervix will be incompetent, it'll open up and just expel the fetus. And so usually we have to do something called a cerclage, literally stitch the cervix closed so it can retain the gestation. Otherwise, the incompetent cervix. Okay, any questions on that? Okay, cancer. Again, most of these are squamous cell carcinomas. There is a small percentage that are adenocarcinomas. The adenocarcinomas really are not related to HPV, only the squamous cell carcinomas are. They can take a variety of different morphologies. Again, peak incidence of about the age of 45. Again, if you suspect that someone has a cervical cancer, you have to confirm it with a biopsy. The prognosis will depend on the stage. The stage, remember, tells you to what extent the cancer is already spread. Is it very local? Has it spread to the regional lymph nodes? Is it all over the place? The stage is an important prognostic factor. Okay, any questions on dysplasia and cervical cancer? Yes.
Just to clarify, CIN3 and CIS are the same thing?
CIS is a type of CIN3. CIN3 is a very severe form of dysplasia. You can qualify it further by calling it carcinoma in situ.
How would you differentiate? Would you say CIS versus other forms of CIS?
CIN3 would be anything above 2/3 of the epithelium. Would be sure. If you have full thickness dysplasia, that's the most severe form of CIN3. You can call it carcinoma. Full thickness dysplasia. Anything else on that? Okay, let's move on to the endometrium. Problem with the endometrium. Let's first take a look at the uterus. It's a normal specimen. Uterus is a relatively small organ, at least a non-pregnant uterus is. It's about the size of my fist. You can see a normal specimen here attached to the vaginal canal. Here's the uterus. That's the cervix, the fundus. You can see the fallopian tubes, the fimbria up here. Ovaries here. You can see the suspensory ligaments here. Everything looks normal. It kind of has this kind of tan color to it. Again, everything in this specimen. First thing I want to mention is endometritis, inflammation of the endometrium. Again, there are acute and chronic forms. Acute forms can usually develop in the postpartum period. They're often caused by retained products of conception, meaning that part of the placenta probably wasn't delivered. So the fetus comes out, the placenta is supposed to be delivered next. Sometimes the placenta doesn't completely detach from the endometrium, and some remnants are left against the wall of the endometrium, part of the wall of the endometrium. It becomes necrotic, bacteria colonize it, and will cause an acute inflammatory response that results in acute endometritis. Usually, the procedure there to cure something like that would be a form of DNC, a dilation curettage, dilate the cervix. Then we go up with a scraping instrument, we just scrape the inside of the endometrium. Passes all that tissue, usually everything resolves on its own after that. Then we have chronic endometritis. Again, that could be caused by a sexually transmitted disease. It could be caused by retained products of conception that have not been removed. It starts off as an acute inflammatory response, progresses to chronic inflammation. Sometimes the chronic endometritis is intentional. An intrauterine device, IUD, is designed to incite chronic endometritis. The chronic endometritis creates a very hostile environment, which the zygote cannot implant, and as a result, it's passed. Okay. Any questions on that? Chronic endometritis. You can sample the endometrium. Usually, you see a lot of chronic inflammatory cells, plasma cells. Really, the key thing with the plasma cells, that's a dead giveaway that there's some abnormal chronic inflammation in the endometrium.
So when they deliver the induced that, that's during pregnancy?
The IUD?
Yeah.
Yeah, the IUD incites chronic inflammation that's intentional. The zygote is supposed to implant into the endometrial mucosa. It can't do that if there's chronic. Generally has a rough time doing that. Okay, any more questions on this? If that's the case, let's take a look at something called adenomyosis. Adenomyosis is a condition where the non-functional layer of the endometrium grows into the myometrium. So you recall there are a couple of layers of endometrium. Let's take a look at that. Here's a section through the endometrial cavity. There's the endometrial cavity up here. Okay. This is the endometrium. And this is the myometrium. Endometrium, myometrium. The endometrium is divided into two layers. The lower layer is called the non-functional layer. And the upper layer is referred to as the functional layer. Now, during the menstrual cycle, the endometrium will grow and proliferate. Some of the endometrium, will be shed. That part of the endometrium that is shed is the functional layer. The non-functional layer remains. It is not shed. It's persistent. However, during cycling, the functional layer will grow, it'll involute, it'll be passed. The non-functional layer always remains. In adenomyosis, part of this non-functional layer, some of the glands of the non-functional layer will grow into the myometrium. It's not a neoplastic process. It's just a process whereby this endometrial tissue just happens to grow into the myometrium. This is a condition we call adenomyosis. Adenomyosis. End up with a lot of glands in the myometrium, the muscular component of the uterus. There's only supposed to be smooth muscle down here. There aren't supposed to be any of these endometrial glands in here. So when the glands grow into the myometrium, we call this condition adenomyosis. Let's take a look. Here's a section through the smooth muscle of the myometrium. And of course, you can see smooth muscle. Lots of bands of smooth muscle here, cut in different sections. But you also see this, these glands. These glands are not supposed to be in the myometrium. Now, they're not abnormal looking glands. Their epithelium looks okay. Cells are not overly crowded. Contours are smooth. Everything about these glands look normal, except they're not supposed to be in the muscular component of the uterus. Okay, this is called adenomyosis. Now,
it's the non-functional.
these are non-functional glands. Part of the non-functional. They grow in there, that's the non-functional glands. This is called adenomyosis. Again, it's not a neoplastic process. These are not neoplastic cells. They're not over-proliferating. They just happen to grow into the myometrium. But nonetheless, this causes some trouble. The myometrium gets irritated by these glands, and it undergoes a lot of reactive changes. The muscular component of the uterus becomes very hypertrophic, and the uterus gets big. One of the symptoms of adenomyosis is an enlarged uterus. Now, because of the way the infiltration occurs, usually the uterus is enlarged symmetrically. It's diffusely enlarged, usually symmetrically enlarged. That's important description. Symmetrically enlarged, uniformly enlarged, not nodular enlargement. Symmetrical, uniform, diffuse enlargement. That's consistent with adenomyosis. Some of the problems with adenomyosis include nephragia, heavy bleeding at the time of menstruation, and also a lot of pain, menstrual pain, dysmenorrhea. Bleeding can be pretty heavy, and as a result, women can become anemic as a result. Now, a couple of different ways that we can treat this. Again, remember the presentation is diffuse enlargement, symmetric enlargement of the uterus. The presentation would include menorrhagia for heavy bleeding, dysmenorrhea, that's pain before menstruation. Women has a couple of choices to deal with this problem. Okay. If she chooses to keep her uterus, one option, of course, is to remove the uterus. We can perform a hysterectomy. Perform a hysterectomy, she's not going to have obviously, it's not going to have bleeding. If she wants to retain her uterus, maybe she wants to have kids or something, we can prevent the symptomatology, menorrhagia, dysmenorrhea, by stopping her cycle. And to do so, we can give her a progesterone-only pill. We give her a progesterone-only pill, she will stop cycling. She obviously will not experience dysmenorrhea, nor will she experience the menorrhagia. The problem, however, in the uterus will still remain. You'll still have these glands. in the muscular compartment of the uterus. If she wants to get pregnant, we could take her off the progesterone and get pregnant. The uterus, assuming the uterus will retain a pregnancy, she would get pregnant. But that's a good option if she chooses not to give up her uterus. Simply stop her cycling with progesterone. If she's done bearing children, it might be much easier for her to have a hysterectomy. Any questions on that?
What is the cause of?
It's not clear. We only know that the glands are non-functional. It's not really clear what happens. Sometimes it can be pretty mild in women. Other women, it's completely, myometrium is completely infiltrated by these things. Anything else? Before we take a break, let's take a look at endometriosis. Endometriosis, this is a condition where functional endometrial tissue is implanted in the pelvic cavity. Whatever the cause, there is ectopic functional endometrial tissue within the pelvic cavity. So because this endometrial is functional, it will grow and involute along with the women's cycle, which means it's going to bleed. Biggest problem with endometriosis is that during the beginning of the cycle, when a woman passes menstruate, all of this tissue is going to degenerate, pass blood into the pelvic cavity, and it's going to incite a lot of inflammation. This causes a nasty peritonitis. The woman is in a lot of pain when she's menstruating. Another problem with endometriosis. This tissue is functional, so when it degenerates, it bleeds. The blood will organize. You know what organization means? We talked about that term. What's organization? Clots and organized means it basically means it scars down. That's a word that you have to know. Organization of blood. Blood organizes. It just basically means it scars down. So there's a lot of scar tissue that forms in the peritoneal cavity. Sometimes you get these very thick adhesions, scar tissue that span the entire width of the pelvic cavity. In addition, some of this scar tissue could seal up the fallopian tubes. As a result, sometimes endometriosis not only causes all this pain and discomfort, but it also will sterilize the woman. Once the fallopian tubes are sealed, she can't get pregnant. That's very often how endometriosis will present: pain and inability to conceive. Okay, let's take a look at some of the theories that have been proposed to explain the presence of this ectopic endometrial tissue in the pelvic cavity. So here we have the pelvic cavity here. There have been three primary theories that have been proposed, still favored, that could explain the presence of this ectopic endometrial tissue. Now, any one of these theories could be right. All of them might be right. None of them might be right. These are the theories that we're generally working with right now. We've got three theories called regurgitation theory, the metaplastic theory, and the lymphatic dissemination theory. Let's take a look at the regurgitation theory. Regurgitation theory proposes that menstruates, refluxes up the fallopian tube, and regurgitates right into the pelvic cavity. And some of this tissue is viable and implants. Okay, and then it'll again grow and cycle along with the woman's period. We have the metaplastic theory. The metaplastic theory proposes that the coelomic epithelium, coelomic just means cavity. Coelomic epithelium is an epithelium that covers a cavity. Okay, some of this epithelium covering the cavity walls, coelomic epithelium, differentiates into this functional endometrial tissue, and again, grows and involutes. Then the dissemination theory proposes that menstruate gets into the lymphatics and the venous system and disseminates that way throughout the pelvic cavity. Again, any one of these theories could be right, all of them, none of them, but those are the ones that are favored most. All right, if a woman presents with symptomatology consistent with endometriosis, again, she's going to have severe pain the time she's menstruating. She may be sterile. She may be important as she can see. Okay? Generally, when we encounter something like this, we just generally give a tentative diagnosis of endometriosis. She may choose simply to want to accept some medical therapy to deal with this problem. One way to treat this, again, would be to stop her from cycling. Stop her cycling, this tissue will also stop cycling. She'll avoid all the pain and the buildup of scar tissue. You do this giving her a progesterone only pill. That may be one option she has. If she does not want to stop cycling, then we would have to do more investigating work first to confirm that she does indeed have endometriosis. Usually that would mean an exploratory laparoscopy. We'd have to explore the pelvic cavity looking for these implants. These ectopic endometrial foci generally are kind of yellow to rust color. And we would look inside, we'd take a look with the laparoscope and look for these little implants. Usually they appear as kind of these, again, yellow, brown, rusty colored nodules. Take a look at that. Here's an example of a laparoscopic image of endometriosis. Again, you can see the pelvic wall here, nicely vascularized. And you can see we've got some nodules here. Some of these rust colors, some are yellow, rusty colored. That's consistent with endometriosis. To confirm the diagnosis, we'd have to biopsy some of these nodules. And in order to get the diagnosis, we would have to see two of the following three things. Endometrial glands consistent with endometrial tissue. We'd have to see endometrial stroma or some hemosiderin pigment. Any two of those three things would get you the diagnosis of endometriosis. Once we establish diagnosis of endometriosis, again, we have a couple of options. Again, we can give the woman the option of simply stopping the cycle, the progesterone only pill, or what we can do while we're in here is we can destroy these implants. We can use electrocautery, usually use an electrode that looks like a little roller, and we roll the electrode over these nodules and obliterate all of this tissue. Sometimes that's very successful. Sometimes it's only partially successful. One thing we have noticed is that the extent of the endometriosis doesn't correlate with the woman's symptoms. One woman can have extensive endometrial tissue throughout the pelvic cavity and only mild symptoms, while someone could have just a few nodules here and there and have really extensive symptoms. There doesn't seem to be any correlation. But those are some of the options you can have. Any questions on that? Let's just finish up again by emphasizing presentation. Infertility, why? Because the fallopian tubes can be scarred shut. Dysmenorrhea, pelvic pain. Sometimes these implants, these little nodules will implant on different organ tissues. Sometimes they can implant on the rectal wall. If that's the case, and during menstruation, she's going to have a lot of pain defecating. If the implants form on the exterior of the uterus, she can experience dyspareunia, pain with intercourse. And sometimes the nodules will implant on the exterior of the bladder. If that's the case, she'll have severe cystitis dysuria at the time of menstruation. Any questions on endometriosis? Okay, take a break.
When did your vocabulary change? Just,
Yeah.
to it. It'll take you probably about 2.5 hours to get through. If you watch the videos, should be okay. Everything is covered in there. Also, I think Monday is going to be the last day to cover any new material on GU. So we need the rest of the week, Tuesday and Friday, to go for questions. That should only take us 2 hours, so we'll have 1 hour left over maybe. Until we do. So that's what I planning it anyway. Anything on the student exam? Okay, also, I was just looking up what was in Gardasil. So Gardasil 9, again, it covers the major ones that we talked about. 6, 11, 16, 18. These, of course, are benign serotypes, and all these others, you know, they're more oncogenic serotypes. So it's like 6 and 11 is it? Okay, anything on that? Okay, so last we were discussing endometriosis, so we finished that up. Next thing we want to take a look at is dysfunctional uterine bleeding. Dysfunctional uterine bleeding is defined as heavy bleeding and absence of any kind of organic lesion of the uterus. That means there's nothing physically wrong with the uterus that you can identify, but yet there's this heavy bleeding. Okay, a few things that we're going to need to know before we understand dysfunctional uterine bleeding. First, we need to understand that estrogen causes endometrial gland proliferation. And we have to understand that progesterone inhibits gland proliferation. And promotes stromal proliferation. Stroma is the tissue between the glands. Okay, let's talk a little bit about this dysfunctional uterine bleeding. Again, dysfunctional uterine bleeding defined as heavy bleeding in absence of anything physically wrong with the uterus. Usually, dysfunctional uterine bleeding is caused by an imbalance in estrogen and progesterone. Any condition that favors increases in estrogen out of proportion to progesterone generally will cause dysfunctional uterine bleeding. So dysfunctional uterine bleeding is caused by an imbalance between estrogen and progesterone, with an increase in estrogen without a proportional increase in progesterone. Any condition that causes that will generally cause dysfunctional uterine bleeding. Okay, let's take a look and see why this dysfunctional uterine bleeding is about. First thing we have to do is take a look at some of the hormonal changes that occur throughout the menstrual period. We have to correlate these hormonal changes with changes occurring in the ovary as well as the endometrium. Okay, so here we have a representation of a period. This happens to be a 28 period. Some women are shorter, some women are longer. We can divide the period into a number of different phases: menstruation, proliferation, and secretion. Let's take a look at this. By definition, day 1 of the menstrual cycle occurs when menstruate is passed through the vagina. That's by definition. That's not the end of the period. That actually marks the beginning of the period. Okay, so day 1, we have passage of menstruate through the vagina. That's day 1 of the menstrual cycle. Again, this can last 1 or 2 days. Women can vary in the time in which they menstruate. Okay, after menstruation, a couple of changes start occurring in the ovary. Follicles begin to develop in the ovary. And as these follicles develop in the ovary, they start elaborating lots of estrogen. They start developing a lot of estrogen. This estrogen has an effect on the functional layer of the endometrium. Within the endometrium, all this estrogen starts allowing the proliferation of glands. Estrogen promotes the proliferation of glands, and the glands in the endometrium, they start proliferating. When this happens, when the glands in the endometrium start proliferating, this marks the beginning of what we call the proliferative phase of the uterus. The proliferative phase of the uterus. And this is caused by follicles developing in the ovary during what we call the follicular phase of the ovary. So we have a lot of estrogen being produced by these follicles operating on the endometrium, causing lots of gland proliferation. Now, during this proliferative phase, again, a lot of glands are proliferating, but the stroma, the connective tissue that's supposed to support these glands, isn't proliferating very much. And so these glands are proliferating without a lot of structural support at the stroma. So these glands tend to be a little flimsy and very delicate. Plush endometrium starts to develop, but the glands that have developed aren't very sturdy. It's very easy for some of these glands to kind of flop over, pinch off their own blood supply, and necrose. But that changes about mid-cycle. About mid-cycle in the ovary, you have ovulation. These follicles is going to ovulate. This ovulated follicle, this ruptured follicle, eventually is going to change into a corpus luteum. And this corpus luteum will start elaborating progesterone. That progesterone will inhibit gland proliferation and promote the proliferation of stroma. So glands stop proliferating. The stroma starts structurally reinforcing these glands. So now the endometrium is very plush and the endometrium is very sturdy because it must be structurally reinforced by this stroma as a result of the progesterone. Now this happens during what we call the luteal phase of the ovary, where corpus luteum is formed as a result of ovulation. The corpus luteum produces progesterone. That has an effect on the endometrium, causing the glands to stop proliferating and causing the stroma to proliferate. This occurs in what we call the secretory phase of the uterus. And so during the secretory phase, we have high progesterone, and again, that stabilizes the endometrium, a nice plush, sturdy endometrium. Now, assuming implantation doesn't take place, eventually the corpus luteum will degenerate, hormones will drop. This will cause involution of the functional endometrium. And again, you have day 1 of menstruation, beginning of the next cycle. So we have this relationship between all of these hormones and the activity of the endometrium. Any questions on this? Okay, I said that. Dysfunctional uterine bleeding, DUB, is caused by an imbalance in estrogen and progesterone, favoring an increase in estrogen without a proportional increase in progesterone. Okay, we'll consider what happens. You have menstruation taking place. Estrogen levels are very high. Estrogen, of course, will cause the proliferation of all these glandular structures. The glands will proliferate, but their structure won't be reinforced by stroma. That's normal for the proliferation phase. Okay, glands develop with no structural reinforcement. That's fine for the proliferation phase. What's supposed to happen next is you're supposed to develop a corpus luteum that will stop the proliferation, reduce progesterone, stopping the proliferation and enhancing the proliferation of stroma to structurally reinforce these otherwise very flimsy glands. Well, in dysfunctional uterine bleeding, you don't have sufficient progesterone. And as a result, these glands keep right on proliferating. And they keep right on proliferating without any structural support whatsoever. They're very delicate, very plush, very delicate. And as a result, these glands, they sometimes flop over, they sometimes necrose, and as a result, women develop heavy bleeding. Heavy bleeding is called menorrhagia. One of the features of dysfunctional uterine bleeding is heavy bleeding, also known as menorrhagia. The bleeding can be quite significant. Now, because no progesterone is structurally reinforcing the stroma, the glands continue to proliferate, and there's essentially no secretory phase. The proliferation phase extends throughout the entire menstrual cycle. No progesterone, means no structural reinforcement of the endometrium. The glands are very flimsy, they're very plush, they're very flimsy, and as a result, when the glands start to flop over, they start to degenerate, a lot of bleeding develops. And so one of the features of DUB is very heavy bleeding. And indeed, the definition of dysfunctional uterine bleeding is heavy bleeding in the absence of an organic lesion of the uterus, meaning there's nothing physically wrong with the uterus. And again, the problem is some sort of imbalance estrogen and progesterone. Any questions on that?
Yeah, Dr. May, just real quick. So why is the progesterone not being secreted?
There are a number of reasons for that. In fact, we're going to look at that next. Okay, but this is the basis for the whole dysfunctional uterine bleeding. There are lots of reasons why estrogen might increase out of proportion to progesterone, but this is the fundamental principle of dysfunctional uterine bleeding. Estrogen increasing out of proportion to progesterone. Anything that does that will cause dysfunctional uterine bleeding. So let's take a look at some of the things that can cause that. Okay, failure to ovulate. Okay. Sometimes failure to ovulate will occur at extreme ages of reproductive life. Premenarcheal, woman's pituitary ovarian axis is immature, it's not hormonally coordinated. Sometimes as a result, follicular phase will develop in the ovary, proliferation phase will develop in the uterus, but because there is no ovulation, no corpus luteum will develop, no corpus luteum, no progesterone. And the woman is left with a uterus that's being stimulated by estrogen without being properly balanced by progesterone. So premenarcheal women, they can develop dysfunctional uterine bleeding. Same thing with perimenopausal women. The pituitary ovarian axis is failing. Okay. Sometimes a woman develops follicles that do not ovulate, no corpus luteum, no progesterone. Same thing happens. At the end of reproductive life, a woman might present with this very heavy dysfunctional uterine bleeding. Sometimes the corpus luteum develops, but it involutes prematurely, and as a result, not enough progesterone is made. If inadequate luteal phase is maintained, then again, estrogen is high out of proportion to progesterone. Some people believe that contraceptive-induced bleeding is also a cause of dysfunctional uterine bleeding. It's not really good. Universally substantiated, but sometimes you take combo pills, very high in estrogen. Sometimes that theoretically or hypothetically that can cause an imbalance resulting in dysfunction. Any kind of estrogenic steroids without any kind of progesterone, again, high levels of estrogen, progesterone, dysfunction. Also, sometimes certain tumors of the ovary, granulosa fecal cell tumors, they have a habit of producing a lot of estrogen with no progesterone balance. They too can present with dysfunctional bleeding. Okay. All right, presentation, in any case, excessive uterine bleeding. In order to diagnose this condition, you have to biopsy and date the endometrium. The way this would work is we first try to establish the period over which the woman cycles. Okay, if she's, for example, 28-day period, what we'd want to do is we would want to time a biopsy of this endometrium such that we should be biopsying the endometrium during the secretory phase. Take a piece of this endometrium when she should be in the secretory phase. If we biopsy the endometrium and discover that the endometrium, which should be in the secretory phase, is actually in the proliferation phase, we know she's being subjected to too high levels of estrogen without properly balanced progesterone. There are differences in the histology of this endometrium we can notice. For example, the proliferative phase, you see how straight these glands look? In the secretory phase, these glands are very convoluted. Very easy to identify proliferative endometrium from secretory endometrium. And so what we do, again, is we would biopsy her endometrium when she should be in the secretory phase. If she's in the secretory phase, everything is fine. We gotta look for another reason she's bleeding. If, however, we discover she's in the proliferative phase when she should be in the secretory phase, we know there's an imbalance in estrogen and progesterone. And that's how we go about making the diagnosis of the FID. We biopsy and date the endometrium. Okay, if we do that, again, the biopsy will be remarkable for proliferative endometrium. It will show endometrial hyperplasia, meaning the glands are clearly over-proliferating, and all of the structures will be consistent with a proliferative phase endometrium. Any questions on this? Yes.
You would say that a patient post, say, 14 days of their pregnancy should be secretion. Is that how it works?
Yes. I mean, generally, what we would do is we would get her entire cycle time, and we would take her entire cycle time and subtract the secretory phase period. This phase of the menstrual cycle is variable. And this phase of the period is more or less constant across women. Okay, this is about 14 days. So, if she is indeed 28-day cycle, we would subtract 14 from 28. We know she's ovulating here. If she's 30-day cycle, we subtract 14 from 30. We know she's going to be ovulating on day 16. So if there's any kind of difference between women and the way they cycle, their cycle period, it's usually because of the menstrual phase and proliferation phase. This is variable. This is pretty much constant, 14 days across all women.
So
Why don't they make a progesterone? Well, there's a number of reasons. Again, they don't ovulate, tumor, estrogen. Maybe they're taking too much estrogen, combo pill. Those are all possible. Okay. Anything else on this? What if two eggs are released? So you have dizygotic twins as opposed to monozygotic twins. Okay, I would imagine you would have two corpus lutea. Two of those. I guess there's a feedback loop that would govern the whole thing. So if you had two sources, it wouldn't mean that like progesterone levels would go through the roof.
Is that whole women living together sync up thing real? One. And two, if it is real, why?
What's this?
You understand that?
it
You're
said
picking up
that
on
if
putting
women,
down?
if
You wanna
women live together, they have the same cycle.
Women that live together, it's presumed they will get on the same calendar schedule as far as their menstruation cycle.
Oh.
Do we know pathologically why that happens? How and why? Same question.
I have no idea.
That's probably more of an existential.
Dr. Matt, you have to know this. You know everything. Just a logical reasoning for it.
Sometimes I think a geologist would be better.
Say that for a few hours.
I seem to remember hearing something. Okay, anything else on this? Open book. Okay, well, let's go on to tumors. Tumors of the uterus. Okay, first thing we'll take a look at are these leiomyomas, also known as fibroids. We've talked about these before. These are benign proliferations of smooth muscle. You very commonly see them in the myometrium of the uterus. They generally develop during a woman's fertile period. They are dependent somewhat on estrogen. Generally, when estrogen levels are high, these leiomyomas grow. When estrogen levels drop, they tend to shrink. In fact, when a woman passes through menopause, estrogen levels drop, these leiomyomas tend to completely involute, and they will calcify, leaving what we call womb stones, or simply calcified leiomyoma. All right, let's take a look. Again, here is a normal specimen. We've got normal uterus, cervix, fundus. Everything is in proportion here. When a woman develops leiomyomas, often they're multiple leiomyomas, and they cause a nodular enlargement of the uterus, asymmetric enlargement of the uterus. This is what a leiomyoma or fibroid uterus would look like. Again, we've got the cervix down here. There's the fundus. You can see overall you've got an enlargement of the uterus, but you also have these very large tumorous masses sticking out from the surface of the uterus. Those are the leiomyomas. Usually leiomyomas are pretty bulky. They can range in size. They can be the size of like a walnut to the size of a watermelon. On how much they depend on an estrogen, how much estrogen is generally available. Okay, depending upon where these different leiomyomas grow within the myometrial wall, we can classify them 1 of 3. We've got intramural leiomyomas that grow right within the wall of the myometrium, subserosal that go right below the serosa, the exterior of the uterus. Here's an example of a subserosal leiomyoma, all of these. Okay. There's an example of an intramural leiomyoma growing right in the wall of the myometrium. And then we have what we call submucosal leiomyomas. These are leiomyomas that grow just underneath the endometrium. The endometrium is considered the mucosa of the uterus. So submucosal leiomyomas grow right under the endometrium. Okay, these can be a nuisance in a number of different ways. They can be asymptomatic. They could cause considerable distortion of a woman's abdomen. Sometimes these go quite large. Again, they can be the size of, I've seen them as big as a watermelon. It can actually make a woman look pregnant when she's not. Sometimes these leiomyomas are asymptomatic. Sometimes they will cause menorrhagia. And they can cause menorrhagia again to the point where the woman becomes anemic. And so there are a number of different procedures in which we can use to cure the situation. If a woman is done bearing children and you have a uterus that's this badly diseased, maybe a hysterectomy is in order. Maybe a total abdominal hysterectomy, subtotal hysterectomy is in order. If the woman is not done bearing children, a lesser procedure can be performed called a myomectomy. A myomectomy is just a procedure where we literally cut out these leiomyomas. They are benign neoplasms, they're well delimited. You just cut into the uterus and literally take your hand and scoop them out. They are very easy to remove, and then of course you just repair the uterus and stitch it back together. That would be a procedure if the woman wanted to still bear children. If she wants none of those things, and again she's having trouble with menorrhagia, heavy bleeding, perhaps we would give progesterone only pill, again, to stop it from cycling. Okay, let's take a look at the histology of these leiomyomas. They are benign tumors. You expect the smooth muscle component to be well differentiated. Indeed, it is. Well differentiated means they look like normal smooth muscle cells. Here's a section through the leiomyoma. Again, you can see the smooth muscle cells running in bundles here. This way, this is a perpendicular cut to their axis. This is a longitudinal cut to their axis. right through a leiomyoma. There's the serosa. And this is the leiomyoma itself. Again, the smooth muscle cells look well differentiated. If you compare them to normal cells, again, the smooth muscle cells of the leiomyoma look like normal smooth muscle cells. Okay, everything is very well differentiated. That's characteristic of a leiomyoma. Grossly, these leiomyomas generally are very well delimited, and they're benign. You cut through them, they generally have a white cut surface. Usually you'll see some sort of whorl pattern in the cut surface of the leiomyoma. Any questions on that? All right, let's take a look at the malignant counterpart. Before we do that, I mentioned before these leiomyomas are dependent on estrogen. Again, when estrogen levels are high, they will grow along with estrogen levels. Estrogen levels drop, they stop growing, they may even improve. Postmenopausally, these leiomyomas tend to calcify, completely stop growing, they'll degenerate, and they'll undergo dystrophic calcification. Okay, sometimes you can see that in a postmenopausal woman. You take a radiograph of the pelvis, you see the remnants of a calcified leiomyoma. Often the calcification has the texture likened to popcorn. So they're called popcorn calcifications. Here's an example of a radiograph of an older woman's pelvis. And you can see she's got a hip replacement over here. And inside the pelvic cavity, you can see these popcorn-like calcifications. Those are consistent with calcified leiomyomas. Apparently, this woman had leiomyomas, may have had symptoms of menorrhagia, decided not to do anything about it, and that the leiomyoma subsequently calcified. Okay, taking a look at the malignant counterpart, the leiomyosarcoma. That's a malignant proliferation of smooth muscle tissue. Now, it was once thought that these malignant leiomyosarcomas, they were the result of malignant degeneration of the leiomyoma. Someone started off with leiomyoma and underwent malignant change and turned into a leiomyosarcoma. That's proven not to be the case. If a leiomyoma ever degenerates into leiomyosarcoma, it's never been done. What the leiomyosarcomas seem to develop on their own. They develop from mesenchymal cells within the uterus, and they develop independent of any leiomyoma. They just develop as a malignant leiomyosarcoma. Now, because these things are malignant, you'd expect the cells to be poorly differentiated. And that's true in most cases. The smooth muscle cell composition looks very different from that of a leiomyoma. Leiomyoma, very well differentiated smooth muscle cells, nucleus, spindle-shaped cell. Everything looks like a normal smooth muscle cell. But the cells of the leiomyosarcoma, while some of them might look like normal smooth muscle cells, most of them don't. Most of them look very odd. They're very poorly differentiated smooth muscle cells. And of course, that's a tip-off that this is malignant. Leiomyoma is well differentiated. Leiomyosarcoma is generally very poorly differentiated. Now, most of the time, you can bank on the cells of a leiomyosarcoma being poorly differentiated, and that's how you can easily identify them. Sometimes, though, you get well differentiated leiomyosarcomas. How do you tell the difference then between leiomyoma, leiomyosarcoma? You look at the mitotic index. The mitotic index, the number of mitotic figures you see per unit area. Generally, leiomyoma, mitotic index can be very low because it proliferates and grows very slowly. It's a benign neoplasm, they usually grow slowly. Mitotic index should be low. Malignant neoplasms usually grow faster. Mitotic index will be very high because mitotic figures per unit area will be high. So a number of different ways to tell the difference between these two. Number one, leiomyoma well differentiated. Usually leiomyosarcoma poorly differentiated. If you want to be sure, check the mitotic figures. The mitotic index of the leiomyosarcoma should be high, whereas the mitotic index of the leiomyoma should be low. Any questions on that?
Those stain differently?
They're not, yeah, the staining characteristics essentially irrelevant. That's a good question. Usually, you know, when a pathologist looks at a section, the staining characteristics are so variable from lab to lab and from day to day that we just even look through these differences. Don't even notice them. Anything else? But leiomyoma is also known as a fibroid when it's in the uterus.
And you said the leiomyosarcomas are usually not well differentiated.
Yeah, the leiomyosarcomas, see that cell right there? And that cell right there, and that cell, they look like smooth muscle cells. Not really. That's poor differentiation. Look at these cells. Most of them look like smooth muscle cells. More like smooth muscle cells.
That was an angry throw.
Angry throw. That's botched. Yes.
So with leiomyoma, with the fluctuation of menstruation, that will calcify. Will the leiomyosarcoma calcify as well?
Leiomyosarcoma would present with problems before it calcifies. So, I mean, it's feasible that something could happen to it. Maybe its blood supply gets cut off and it'll calcify. But usually this will grow, metastasize. Pleomorphic nuclei just means they're very different. See how the nuclei are very different? See how the nuclei are very uniform? To be well differentiated, they have to be uniform. They have to resemble normal cells. Okay. Anything else? Endometrial cancer. Let's take a look at that. It's probably the last thing to cover for today. A couple of things to know. Endometrial cancers are adenocarcinomas. Adenocarcinomas. They are typically cancers that develop as a result of some sort of atypical endometrial hyperplasia, meaning the glands proliferate abnormally. As they're proliferating abnormally, they're accumulating mutations, eventually allows them to become endometrial adenocarcinomas. Important to understand, peak age for the development of endometrial cancers is between the ages of 55 and 65. That's during the postmenopausal period. That's important because the most common presenting feature of endometrial cancer is postmenopausal bleeding. Postmenopausal bleeding. I mean spotting, I mean bleeding. Postmenopausal bleeding. You see postmenopausal bleeding, that should be a red flag. The first thing on your differential is going to be endometrial carcinoma. So that's how frequently it presents. You have to rule it out. Okay, let's take a look at this endometrial carcinoma. Let's first take a look at normal endometrium. Here we have a sculpted dissection of the uterus. Okay, this time it's been sectioned right down the endometrial canal. So we can see, of course, the cervix is over here. There's the endometrial canal. And there is the endometrial cavity. Right? Look in the endometrial cavity, you'll see this kind of triangular area. That is the endometrium. It's not too impressive. That's what the endometrium looks like. Okay, of course, we got the fallopian tubes here and the ovaries over here. This is what a normal uterus looks like, normal endometrium. Take a look at the walls of this uterus. Most of that wall is made out of myometrium, muscle. The uterus is a very muscular organ. It has to expel a whole child. And so even when it's not pregnant, most of the wall thickness is made out of myometrium. It's very thick, nice uniform myometrium that you see there. All right, if that is a normal endometrium, this is what endometrial cancer looks like. We got the cervix over here, and the uterine cavity should be over here. Take a look at this. And we're sectioned through the uterus. There should be a uterine cavity visible. Instead of the uterine cavity, you see all this kind of yellow white stuff. This is the cancer. This is all endometrial adenocarcinoma. You can take a look and you can see that this cancer is infiltrating. Look at the wall of the uterus. There's the wall of the uterus, mostly intact here, mostly made out of muscle. Look what happens over here. And look at all this white yellow stuff. It's infiltrating the wall of the myometrium. That's local invasion. That's clearly a cancer. It's clearly invading into the wall of the uterus. Now, as it invades the wall of the uterus, it's going to rupture some blood vessels. The blood vessels are going to bleed. And as the blood vessels bleed, it trickles down through the endometrial canal and out the cervix. And that's why women with endometrial adenocarcinoma present with postmenopausal. Okay, this thing ruptures blood vessels, comes out. Okay. All right, so this is adenocarcinoma. So you know what the histology is going to look like. You're going to have a lot of crowded glands, very atypical looking. Let's first take a look at normal endometrium. There's normal endometrium. This happens to be what we call normal proliferative endometrium. Okay, we can see stroma over here. And of course, we can see the glands over here. I know that this is proliferative endometrium because the glands are nice and round, nice and straight. Okay, everything looks good here. We've got stroma between the glands. All the glands are separated by stroma. Okay, this looks like normal endometrium. That's normal endometrium. This is adenocarcinoma of the endometrium. Look at this. We've got crowded glands. Very atypical looking glands. There's very little stroma between these glands. Some glands have no stroma between. Epithelium of these glands, very crowded together, making very convoluted, pleomorphic, crowded looking cells. That's typical of an adenocarcinoma. Just what you'd expect. It's an adenocarcinoma. Very little stroma. And that's because the stroma is not neoplastic. Only the glands are neoplastic. Adenocarcinoma, only the glands are neoplastic. And that's why you have very little stroma here and lots of glands. Okay, any questions on that? Yes.
Will the bleeding in this case be like random at any time? Or will it be cyclic?
It's going to be periodic as the cancer breaches the different blood vessels.
But it won't
It's
be
not
like,
going to be. It's not going to be regular bleeding. It'll happen, I guess, sporadically. But it'll be. It won't be just a little spotting. It's not going to be like pink fluid. Okay. Any questions on that? All right. So we're gonna finish this up on Monday. That's the last day we're covering new material. Tuesday and Friday we'll spend going over the questions. Hopefully we'll have an hour left over to review it.